Good afternoon, everyone. Thank you for joining us for this episode of the ACRO podcast. My name is Tarita Thomas. I'm the chair of the Government Relations and Economics Committee of ACRO, and I'm here with Teri Bedard. Thanks so much for joining us. She is the Executive Director of Revenue Cycle Coding Strategies. She's worked in healthcare for over 25 years and is here to share her expertise with us about the new changes that are going to be coming up soon in terms of the public health emergency and the fact that actually the public health emergency is ending. We are seeing the light at the end of the tunnel here. So to start with, Teri, again, thanks so much for joining us. I do want to start by asking you the question of, can you give us a time frame of how long this has been going on, when the actual last date will be, and how will we resolve all the changes that have happened through this PHE? I'll just call it PHE going forward.
Oh, thank you, Tarita. And it's great to be here. We've been doing the public health emergency. We've been really under this since January 30th of 2020. So a little, the 3 years going a little over the 3-year mark at this point. And there's been a lot of waivers, a lot of extensions that really started in March of 2020. That's when the rules came out from Medicare to make a lot of these waivers that came through. And there was, over 1,000 of them. I mean, there's a lot of them that has been in this process. And so what happens is the magical date is May 11th. So that's so that'd be Thursday coming up here, is when that actual final date ends. And that's what's been set by the government. That's been, that affects Medicare. It affects, even commercial payers that are allowing or have been following the public health emergency, some of the waivers that they've been doing as well. That's the end date. So it's really that May 12th, that next day when there are things that are going to revert back to how they were pre-pandemic. We've got some things that are it's really a 3-phase process. So then we've got things that'll happen and change at the end of 2023. And then the next phase will be at the end of 2024. And that's what we know so far. It's possible things could change, but that's what we're looking at right now is those 3 main phases of things that are going to be adjusting and changing back, or to some extent what they look like before.
Can I ask, I know that we had an extension of the PHE several times over that 3.5-year period. Based on everything up to now, because we're 6 days away or so from this end date, is there any possibility of it being extended, or we should march forward confidently that May 11th is going to be that date?
Yeah, it's set as May 11th. One of the things that was really part of this whole process is that once a public health emergency is extended, and they have them for multiple different things. There's one for the opioid crisis that's been ongoing for some time. Once they extend a public health emergency, it lasts for 90 days. And it can be adjusted to a shorter time frame, but every 90 days it kind of re-ups if they continue it. The thing with the one related to COVID is that part of the whole process is that the government or the president has to give a 60-day notification, 60-day notification to the governors to say, hey, this is going to be ending, so that they have some, way to prepare and kind of get things in order as well. And so if they were going to extend it again, they'd have to kind of go through this process to give, some more updates and kind of allow for that change to happen. So it is set. It's been set for a couple months now. It was set in January, they announced. So they gave even a longer time frame to prepare for the end. And even in the last few days, in the last week, Medicare has been releasing a lot of different updates, or not updates, but information and guides and different ways of formulating the information so people can have some access to what's happening, what's changing.
Okay, well, so May 12th, the world that we know in terms of healthcare, specifically regarding televisits, I wanted to hear your thoughts about that. In my practice, we do quite a few televisits, as it's in certain instances more convenient for the patient if they live far from our center or if they're elderly. What is the suggestions, or what are the rules regarding televisits going forward May 12th?
Yeah, so that's the one that's probably that's going to be with us the longest, but there's some components of it that are going to change. So starting May 12th, you do have to use a HIPAA compliant audio video capabilities for that real-time visit with the patient. Up until now, it's been a really strongly suggested that's HIPAA compliant, but they haven't been enforcing that. So if there was an infraction, they weren't going to go after for any penalties and so forth. But now they are. You have to use HIPAA compliant software starting May 12th. So making sure that if you're using Teams or some kind of FaceTime software, that you have the HIPAA compliant version. A lot of them will have that, some don't though. So making sure that's understood. But telehealth in of itself has really been a focus even with Congress. And so that's what happened really at the end of 2022 in December, where they've extended telehealth. So taking a step back, we've always had telehealth services. It's just been really in those rural, hard to staff locations, much more so. And in a hospital setting, the patient had to be in like a hospital area or department to use their technology. We're going to continue to have those telehealth services until the end of 2024. So December 31st, 2024 is the last day as of now that telehealth is going to be this wide open where patients can be, they could be at an office, they could be at their home. The physicians at the end of this year, they will have to be in their offices. They will have to be in their departments. They will no longer be able to be at home and providing telehealth. So one transition, the first one has to be HIPAA compliant starting May 12th. Starting January 1st of 2024, the physicians will have to be in their own physical location where they practice. They won't be able to be at all these other locations to do this. That has changed. And then January 1st of 2025 is essentially when telehealth as we know it with everybody else outside of what it used to be, it will no longer exist. And that's, there's a bill in Congress that's been pushed, that they're working on to say they want it widely accepted again as permanent. And until January 1st of 2025, physicians will be paid the same as they have if it was it was in person versus virtual. So that's still happening for at least the next, 18 months, give or take. But so telehealth is here. I think one of the things for radiation oncology and you said that, that you use it quite a bit is that we really need to show that there's that support. Mental health services have really shown a lot of utilization. So a lot of legislation, a lot of rules from Medicare have been focused on mental health and maintaining it. I think for radiation oncology in particular, if we really want to show that this is something our patients need and we use, we want to make sure the data is there, that we can support that argument to keep it going even after all of these, these phases end.
That's a very interesting point, Teri. I think that this might be a future podcast discussion topic. Just wanted to touch upon the concept of having the physician in their actual space as the second phase. Has the government provided us regulations or rules to follow in terms of how they will be able to capture that location of the physician? And, for practices going forward, where can they look for information regarding this?
Yeah, I mean, some of the stuff is, when it comes to billing, there is an honor system to it, right? I mean, you're doing a service, when you submit that claim with those codes and that data service, the quantity and so forth, you're saying that, I'm attesting that I did this work. There's an attestation statement on the back of every claim that you submit to payer saying that, yeah, I'm attesting that this is accurate, that I did what I'm billing for. And so the documentation right now, if you're still doing telehealth visits, there should be an indication of where the physician is and where the patient are, where each of you is respectively located to kind of help support that. And so it's clear, and then identifying the documentation that's a telehealth visit. So for that patient, even if you're still doing it when the physician, starting next year, that physician would have to be in their office, or they would have to be, the radiation oncology department if it's a hospital based, whatever that's located. Still identifying as telehealth because the patient may be at home, but you're in your office, at whatever the address or wherever you're at, just kind of that indication there. And then you would bill for it. We'll have place of service codes that can be used that will reflect where the patient is. Those will really go into effect. Right now, still in 2023, you're billing for, if you're working in an office, you're putting place of service 11, even if you were at home and the patient was at home, or if you're in the hospital, outpatient, place of service 21. So we're still kind of, still billing as if we were in the department, but next year we really have to be there to do it.
I see. So there are a few other things that will be changing from May 12th onwards, a couple of other things that we have highlighted in our ACRO Insights. Yeah. So there is more information about this topic. Include the fact that certain physicians in terms of their scope of practice or where they're practicing in which states may change. Can you speak more about that, Teri?
Yeah, so really when you thought about the pandemic and what was going on, there was a lot of need for physicians to be able to step in to assist. And, with quarantining, people becoming exposed and just the emergent level of care that was needed, it was really to kind of bring in access and physicians wherever they could and however they could do that. So sometimes it was providing virtual services so that other physicians could be in person, providing that acute level of care while someone else could be doing some of the virtual stuff that could be done that way. And they could be out of state or could be in a different state. Maybe they weren't necessarily licensed in those particular states. What Medicare has really kind of stepped back from, they've done this on some other things in the past with other stuff not related to public health emergency, but they're really having the states defined. So if you can practice within that state. So now, as we move forward, what's going to happen is that you have to see if your licensure as a physician allows you, if you live in, let's say you live in Illinois, can you also provide services in Minnesota? Do you have to be licensed there? What does that allow? You'd have to look at Minnesota state. They would have to tell you as a physician if they would allow some of that cross coverage or cross state type things or not. And Medicare is really kind of stepping back from that. So if during the public health emergency for COVID, a physician's been providing services virtually or through, out of state, they're going to have to look at that particular state level of guidance and their requirements for licensure for medical services.
So that's a very important point, because you, in the past, at least with this PHE, you were able to work outside of your state, and we all know we need state licensure in terms of being physically present. So this is going to be a big change. There are a few other things that are going to happen. I was just wondering whether you could touch upon what is changing for resident physicians in terms of the PHE.
Yeah, so a couple of things, as we've been kind of going through, even before the COVID, pandemic started, it's really been kind of a revamping and looking at what's required of physicians, teaching physicians with their work with residents, and knowing and understanding that, making sure there's not a lot of duplicative work that's happening. So when it comes to, teaching physicians and the work that's provided for that particular physician that's, working with those residents, they still have to provide that supervision. So when it comes to some of those services, we can't count time, we can't count certain things that residents doing, like with E&M visits, our consult visits, only for what the physician is there and present. There is some ability for the physicians, those teaching physicians, to provide some of that supervision through that real-time audio video capabilities, but that will be transitioning out. And so just kind of knowing that it's really kind of bringing it back home into what's traditionally been when it comes to teaching physicians and some of the residents, and making sure that there is, that direct supervision that's happening for those services, that there's their ability to respond to and provide that assistance and education to the residents. So knowing that it's really kind of coming back a little more in-house, so to speak, a little closer.
I see. I see. Thank you for going through that. Now, you mentioned a second phase, and the second phase starts December 31st, 2023. Is that correct?
Well, so that's when the last day of that second phase.
That's the end.
Really,
okay.
Like January 1st, 2024 is like when the next, we're in our next change of stuff.
Okay. And so January 1st, 2024, some of these parameters regarding televisits, as we talked about, are going to be coming into play. The second phase of the televisit location for the physician is going to come into play. Can you speak a little bit about the treatment management visits? Because that is something very unique to us in radiation oncology.
Yeah, it was really interesting, when the telehealth codes were updated. So this is a list that Medicare puts out every year at the time of final rule. It's an Excel spreadsheet that they put together, and it can be requested to add codes on there. You have to justify and has to go through the proposed and final rule process. But one of the codes that was added for telehealth during the COVID public health emergency was 77427, which is our physician management code, our standard one, right? For every 5 fractions of treatment, a physician gets to bill for this particular code. Now we have 4 four other codes that are also physician management that weren't included. So none of our stereotactic ones, none of our short course, none of the interoperative. Those were all have still had to be provided in person. But for those patients under standard, what you want to call just a standard course of health, 3D, IMRT, even, a 2D or isodose plan course, that's the code you could bill, the 77427. And even now, so through the end of 2023, you can provide your physician management visit using that real-time audio video capabilities. And so you can, document that, you make sure it's clear there was, by telehealth, but the physician can do that. What happened is that as we were looking at possibly when the public health emergency was going to end, Medicare talked a little bit about physician management, and they thought it was difficult for radiation oncologists to really kind of manage their patients, kind of do some of those exams that they might need to do. How are they doing in the course of treatment through a virtual type of setting? And so they have really said, okay, once the public health emergency ends, this is going to end as well. We're going to give you till the end of the year to kind of phase it out. So if any radiation oncologists are performing their weekly management visits using 77427, just know that January 1st, 2024, you will have to do those in person with the patient, no longer through the telehealth use.
Okay, that's a really important point. Sometimes we still do use that in our clinic from time to time. So that's something we should all keep in mind. Now, there are other aspects in the phase 2 that you've touched upon. One of them that I wanted to just hear more about from you is this prolonged outpatient office visit code and how this code may change in its utilization during phase 2.
Right. And so within the ACRO Insights article, which should be coming out here shortly, it really kind of goes through some of these kind of in a bulleted process. So it's kind of easy to see some of those. But it's interesting that this G code, it's a Medicare code. So any code that starts with the letter G, Medicare created. It's G2212. It's a prolonged service. They don't like the AMA code, so they created their own code. But what that means is that, so starting January 1st of 2024, so next year, if you're going to be doing an E&M visit with that patient that's a Medicare beneficiary, and you're using time and you're going into a really long extended visit and you want to use this add-on code to bill for the extra time you're spending with them, that patient's you're going to have to do that in person. So they're taking that code off the telehealth list, which means that E&M, so we just talked a little bit ago, remember E&M and telehealth is going to go through the end of 2024. So we have almost 18 months, but because this one code from Medicare is going to be shortened, the availability of it, then it could shorten some of the, if you were doing another visit, you're doing your E&M and you wanted to bill extra time to Medicare. So just be aware of that one.
That's interesting. So is that going to be more than the 60 minutes for the highest level?
Yeah, so that would be, spending more than 60 minutes, more than, any of the outpatient ones, correct. That level 5 would be greater than level 5. Yep.
I see. All right. Well, that is a long conversation, and it's interesting how there are certain codes that are changing throughout this process and others aren't. I just wanted to now move forward in terms of, for phase 2, Teri, is there anything else specific that you think our listeners should be aware of before we move to phase 3?
Yeah, I think one of the bigger ones, and I think supervision, is always one of those things that trips people up to some extent. And so one of the things to remember for in the hospital setting is that physician supervision for hospitals under Medicare went to general supervision January 1st of 2020. So this was pre-pandemic. What happened then as part of the COVID response is that for those in the office setting, it was still expected to have direct supervision. Physician has to be in the office suite. That's the guidelines for Medicare. What they've allowed is that the physicians could be providing direct supervision using real-time audio video capabilities to kind of give them that expansion, of where they can be for these services. It's also allowed for sometimes for some of the diagnostic tests, certain procedures could be done using the same type of supervision. So some, diagnostic imaging and things like that. That's going to end at the end of 2023. So right now we're looking at supervision for certain things. It's going to go back to where it's always been, where the physician has to be in that office suite. They have to be, readily available. So some of those extensions and waivers that's kind of allowed the physician to be in different places is going to be coming to an end. So making sure from a process standpoint, working through and thinking what some of those impacts are. is going to be huge, I think.
So in terms of procedures and radiation oncology, I'm just trying to think through this. Would you be able to provide a scenario for that, or is this more in terms of like a diagnostic radiologist working through this sort of management?
It would be some of the imaging, but if we even think about, treatment delivery. So treatment delivery is a technical only service. So, if it was something we're just doing treatment delivery, or, even physics services are technical only. So the physician still has to supervise treatments. They still have to supervise physics services. They mean the physicist works under the physician. But so they've been able to do that where if they weren't, if they're not billing for anything with a professional component and things like that, they could provide that supervision in that way. And so now they will have to be back in the office and not, making sure they start early, whatever's going on, that there's a physician that's present for that supervision that's required.
I see. That was very helpful. So phase three is not for some time. So we have some time to work through this, but this takes effect January 1st, 2025. So in this process, that's when the PHE it ends on May 11th, and then the process of kind of dissolution of it now is going to end in that period of time. There are a number of things that need to happen before that date. One of them, again, this televisit ability that we've had, it's kind of ushered in a way, though you mentioned it's been going on even before the PHE. I think maybe it was not as readily utilized by so many of us. What are your thoughts about how this could evolve and what sort of advocacy physicians might need to provide to help our leaders think in a different potential way about utilization of telehealth services?
Yeah, it's kind of one of those things where, you rip off the Band-Aid and, it's, this is going to be a hard one to put back in the jar, so to speak. I'm trying to get my, my things together in the right way, but I think it's going to be difficult. I think there will be some expansion of telehealth. I think it's been proven that it's needed. It is utilized. Everybody previous to pre-pandemic, everyone's like, hey, let's just do it from a telehealth standpoint. The reimbursement hasn't always been the same. It's been a little different in sometimes. And it's usually just much more consultative stuff. So I think as we move forward, until that January 1st, 2025, physicians are going to be paid the same for visits, whether they're in person or virtual. That's not guaranteed in 2025. We don't know nobody knows what that's going to look like at this point. So it's very much there could be different reimbursement for different codes. We could have different codes. The telephone only visits are going away, which they really weren't allowed first for Medicare. They kind of quickly made a change 1 month into this whole waivers that were extended from Medicare and said, oh, we've had a lot of pushback. Medicare beneficiaries like the phone, true phone calls as opposed to video stuff. So I think there's going to be something. There is a bill that's, like I said, it's been proposed. I think there's something to work through to get telehealth permanent. It's just a matter of, what that's going to look like financially with some other changes and things happening. So I think we're looking at some things that will be moving us forward.
Well, I think you've made some really excellent points that telehealth, I feel and agree that is here to stay. I think in what type of formulation it'll come about is really the question mark in terms of reimbursement and a breadth of utility. And I think personally, I feel that advocating for our patients and for our practices is really important with this really great tool. Can you speak a little bit further, Teri, about other aspects of phase 3 that we should all try to keep in mind as we move forward?
Yeah, I think one of the big things is a lot of the stuff that we've been talking about today is really related to Medicare. So know that your commercial payers very different. A lot of them really kind of signed off on some things much earlier. They were very much on board with Medicare when things really first started, but as it continued on and on, they've really made some changes quickly. Also know that it's possible Medicare Advantage plans may offer some additional services. They have to provide at a minimum what Medicare allows or requires, but they can offer some additional things when it comes to telehealth. So that some things may look a little different for Medicare Advantage, some of the ACOs, as well. So I think as we continue to move forward, I think checking in with ACRO, looking at, the ACRO Insights article, there's some tools that are in there. There's some links for information. Medicare has been quickly putting out a lot of information here at the beginning of May to also help prepare, make it a little more concise so it's easier to digest. But I think it's really just staying on top of, and if there's questions, reaching out to any of the members from ACRO, reaching out to the GREC, if they can, to kind of, get some of that support and say, hey, or this is what we're seeing. We thought this is what was the change, and now this is what's happening. We need some assistance or some clarification. So I think it's just trying, it does end here coming up soon, the public health emergency, but like you said, we're going to be looking at this for the next, 18 months, give or take. And so everybody's got to kind of stay on top of where they're at with stuff. But there's a lot of, I think, resources out there.
Fantastic. Teri, thank you so much for this really informative discussion. I appreciate your time and your knowledge in terms of trying to help us all learn more about this process. So thank you all for tuning in, and have a good rest of your day.